Welcome to today's webinar, Value-Based Payment Strategies for Pharmaceuticals. I'm Georgia Maharis, Project Director for the Vermont Healthcare Innovation Project, as well as Deputy Director of Healthcare Reform for Payment Delivery System Reform at the Agency of Administration. I will be moderating this afternoon's webinar. This event is part of the Vermont Healthcare Innovation Project's webinar series, which presents a webinar on a new topic monthly on the second Wednesday of the month. Before we get started, I'd like to go over a few items so you know how to participate in today's event. On slide 2, on the left side of this slide, we've included a screenshot of the webinar's attendee interface, the control panel. You should see something that looks like this on your own computer desktop in the upper right corner. You're listening in using your computer's speaker system by default. If you would prefer to join over the phone, just select telephone in the audio pane and the dial-in information will be displayed. Moving on to slide 3, some housekeeping. We've set aside time for discussion and questions at the end of this webinar. You will have the opportunity to submit text questions to today's presenter by typing your questions into the questions pane of the control panel. You may send in your questions at any time during the presentation. During the question and answer session, we'll have a moderated discussion to answer your questions. Today's event is being recorded. The slides and recording will be posted to the VHCIP website, healthcareinnovation.vermont.gov, within the next few days. You will be notified when these materials are available. At the end of today's event, you will be redirected to an evaluation survey. Please complete this survey. We value your feedback. Finally, I want to thank Chrissy Geiler and Sarah Kinsler for planning this webinar and taking charge of logistics for today. Moving on to slide 4. Our presenter today is Marge Huey of Baylett Health Purchasing. Marge's work at Baylett centers on strategic planning, practice transformation, quality comparisons, cost-saving strategies, payment reform methodologies, organizational operational readiness, administrative simplification, and consumer education and engagement. She has worked on patient-centered medical home and health home initiatives in Massachusetts, Missouri, and Pennsylvania, and works with several local governmental entities, like Vermont, to develop long-term cost containment strategies regarding healthcare costs. Marge has a diverse and rich background in managed care and healthcare law. She has over 12 years of management experience in managed care organizations, having held director-level positions at Tufts Health Plan and Harvard Pilgrim Health Plan in Massachusetts, working in the areas of provider network development and pharmacy benefit management. Prior to moving into healthcare administration, Marge practiced healthcare law in both Michigan and Massachusetts. Marge earned her undergraduate degree from Pitzer College, her law degree in MPP from the University of Michigan, and her MBA from the Simmons School of Management. Welcome, Marge, and thank you for joining us today. We'll start today's discussion, going to slide 5, by hearing from Marge as she describes key issues in pharmaceutical payment and strategies to move toward value-based payment in this area. We will end the hour with some time for Q&A. And now I'll turn it over to Marge. Thank you.
Thank you very much. It's an honor for me to participate in this webinar series. So on to slide 7. What I want to do is to start by giving you some background on what's happening in the pharmacy business and purchasing environment, because you need to understand that as a way to understand why cost increases are going, prices are going up so quickly in this area. We're then going to focus on what we're calling value-based payment or value-based pricing, which is one of the strategic responses to the increased prices, and looking at 4 different types of value-based pricing: effectiveness pricing, performance pricing, indication-specific pricing, and cap on financial exposure. Then we'll move to a discussion on the applicability of those strategies to commercial and state purchasers and to the legislature. Next slide. So it's very important to understand that there is what I'm going to call a tectonic shift going on in what types of drugs are being developed to address illness. Historically, pharmaceuticals have been chemically based. Those are the drugs that are in pill form and available from your local retail pharmacy. You can put them on your shelf. They're easy to store. They're easy to administer. Large manufacturers such as Pfizer are in the business of developing these chemically based drugs. They have a whole pipeline of what's going on in terms of new drug development historically. And then there has historically been a fair amount of competition among drug companies to treat the same condition, so that there has been opportunities to pit one drug manufacturer against another one in terms of pricing by pharmacy benefit managers or very, very large purchasers. And these drugs are relatively easy to duplicate, so that when the drugs go off patent, there can be numerous generic drug companies ready to create generics when patents end. So that's the historical environment that we've come from. We're, next slide, moving into a new world where instead of the chemically based drugs being the predominant drugs, we are moving into a world where eventually biologically based drugs, which are also called specialty drugs, are going to dominate the marketplace. And in fact, they're expected to be 50% of the market in as little as 2 years from now. Right now, I think they're around 30%. So they are just growing exponentially. And what are these specialty drugs? They're biologically based. They're genetically based. They're protein based. They are not chemically based. They often require refrigeration or other kind of storage. They're usually administered through injections and not pill form. They're often available only through specialty pharmacies or through the doctor's offices or clinical facilities, including hospitals. Your oncology drugs, your IV oncology drugs are examples of those. A lot of the new drug development now, instead of being done by huge manufacturing companies, are being done by hundreds of small biotech companies. They're getting venture capital money, and then these folks are developing it as well as the large manufacturing. But most of the development is really being done by these small biotech companies. And so as a result, these large manufacturing companies are feeding their drug pipelines most often by purchasing these little biotech companies. So market consolidation is occurring. And then biosimilars, which are the drugs that are manufactured once the patent ends, are harder to create and are called biosimilars because they're not exact duplicates, but are indicated as similar to those drugs. So it's a different marketplace that's emerging in terms of the kinds of drugs that are being developed, who's developing it, how they're distributed, and also the impact they're having. Because, for instance, we're hearing from the hep C drugs, it doesn't just control the illness, it cures the illness. So they're seeing some rather dramatic outcomes from the biotech drugs. So what's happening is that that there's some dynamics in the marketplace that are then leading to these price increases. The companies are developing targeted specialty drugs with a very strong focus, and as a result, there is very limited or no competition. As an example, the hep C drugs, which have been in the news a lot, the price only started coming down when a second manufacturer came in, and now there's only 3 companies in, and there's not a lot of incentive to lower those costs dramatically. They've sort of reached a plateau right now. Same thing's happening right now with a new class of cholesterol drugs. These are injectables, and that those prices remain high because there's limited competition. Overall, also, there's market consolidation going on, so there's fewer competitors. In the brand world, there's 10 companies that control over 33% of the market in the world. I'm sorry, I don't have that on a U.S. basis. But for the generic world, there's 4 companies that control over 50% of the U.S. market. So specialty markets are developing, There's drug consolidation, both in the old traditional world as well as the new world. There is a change in culture, and I show that through two examples. The ex-Merck CEO was interviewed very recently, just a couple of weeks ago on NPR. And when asked about how important shareholder return was, or shareholder value was, the CEO said that the company took the long-term view to focus on patient welfare, and as a result, shareholder value would evolve and come about. The Turing CEO, in contrast, has recently been charged with criminal activities around drug pricing. And this is the guy who bought up a bunch of licenses to generic drugs and then upped the price hundreds-fold to get a quick return. So there is a very different mindset within at least a subsection, a subsector of the drug world, drug environment. There's opportunistic pricing going on. I just read a little article today which indicated that the price of the drug overdose drug naloxone was increased 60% in 2014. So there's basically an elastic demand for that drug, so they can raise the price significantly. Other things that have been going on that have impacted the prices, there's been a temporary or permanent exit from specific drug markets. There have been production problems, particularly around some of the vaccines, that have resulted in higher prices. But then there's also been strategic decisions to leave the market and move resources into a more lucrative area of the market. There's been a few examples of generic drugs returning to brand status. A very popular brand, inhaler, had its propellant recalled, and so the new propellant is a brand propellant, and so the whole drug went back on brand status from generic status, increasing the price. And there's a new phenomenon where captured mail order pharmacies are used. Those are mail order pharmacies that are being used exclusively by certain drug manufacturers. So this controls access to the drug. And one story I read indicated that this mail order pharmacy kept submitting requests for payment at different price levels until they figured out what price the health plan would pay for the drug. So every time it got rejected, they lowered the price slightly and resubmitted it until they got it to the point where it was accepted. So that's increasing prices. So on the next slide, slide 12, there's a graph here that shows increases of drug prices between 2008 and projected into 2016. And wanted to draw your attention to the brand prescription price index, which has increased 164% since 2008, compared to the next line down, which is the consumer price index, which has increased 12.5, it's increased 264% compared to 112%. So over double the increases. Looking at the next slide, focusing on the last set of bar lines, which is the specialty drug, you can see that the specialty drugs are increasing at a rate that is almost double for the prescription drugs overall. And then the last chart on slide 14, looking first at the bottom, I would call that mustard-colored line. You can see between December 2010 and December 2012, there was a decrease in generic prices, which was very welcome. But since December 2012, they've really shot up. They're still below the general inflation, which is the next line up, which almost looks black, but still shooting up. But then you look at the 3 lines above, which are the brands, a combination of brand and generic, and then specialty drugs. They are at rates of increase significantly above the general inflation rate. So what are state governments doing? There's 2 general responses that are going on, and this is on slide 15. They're enacting drug cost transparency requirements, and we see California, Oregon, Massachusetts, North Carolina, Pennsylvania, New York, Virginia, and Vermont considering, and Vermont actually enacting this legislation. And what it does is it requires manufacturers to submit cost information, which ideally would be made publicly available. Not surprisingly, this is facing very fierce opposition from PhRMA, which is the drug manufacturing lobbying arm. There's another set of legislations that limit copays. Delaware, Louisiana, Maryland, Maine, Vermont, New York are considering those. And some specialty dollar caps are set on copays for specialty drugs, such as any drug copay on level 3 cannot exceed $100. Other limits the rate of annual increases on copay amounts to a certain percentage. So on the next slide, look a little bit more on the groundbreaking Vermont Pharmacy Cost Transparency Act, which was just passed at the early part of June of this year. So this act requires the Green Mountain Care Board, working with the Medicaid agency, DVA, to identify up to 15 prescription drugs annually and give that list to the AG. And the types of drugs that they're looking for are ones that the state spends a significant amount on and ones that have experienced substantial cost increases of at least 50% over the past 5 years or 15% over 12 months. Then the AG sends a data request to the manufacturer for them to justify why those prices have gone up that way, those levels. And if the manufacturers do not report, the AG may impose civil penalties for failing to report. Once the AG gets the information requested, the AG is to analyze the information and submit a report to the legislature and to the Medicaid agency every year. There is a caveat, and that is that the information provided to the AG may not be disclosed in any manner that allows for the manufacturer to be identified. So that means no drug names and no manufacturer names. And it may also, depending on the drug and its use, it may also limit the explanation of how the drug is to be used. Now, obviously, this is not full transparency, and I am assuming that this is the only way, by limiting disclosure, that Vermont could get such a statute passed. Massachusetts has another similar statute, bill in the legislature, but it has not been enacted. But I wanted to draw attention to the types of information that it's seeking. So it's seeking similar information that Vermont would seek, including manufacturing, advertising, and research costs, but also federal research outlays, because there is a feeling that the federal government puts a lot of money into drug research and then doesn't get any benefit back, with the benefit going to these biotech and other drug manufacturers. And then also information on what prices are charged in the U.S. compared to other countries, because again, there's concern that the U.S. is bearing an unfair burden in terms of costs, manufacturers justifying those costs by the cost of developing the drugs. And there's a feeling that that burden of drug development is not being shared fairly. And then finally, the Massachusetts bill provides price relief to publicly funded health programs, which would be the Medicaid program under certain circumstances. Massachusetts Attorney General has also notified Gilead, which is the Hep C manufacturer, that it may face unfair trade practice action if it does not lower its price. And this is unfair trade violations are part of a broader consumer protection statute. I also note that in California, there's a ballot initiative to limit the state drug prices to what the Veterans Administration pays. And this is a controversial ballot question. It's controversial within the pharmaceutical, medical, and advocacy communities. There's different views as to whether this really will save money. There's concern that the manufacturers would respond by increasing the drug prices paid to the Veterans Administration, or paid by the Veterans Administration. So would raise drug costs for everybody. That's coming up for a vote in November by the California voters. On slide 18, there are responses that are going on in the purchaser community to what's going on in the drug manufacturer community. So we see national insurers merging to increase their negotiating leverage. We've got the Aetna Humana, Anthem Cigna, Centene Health Net. In fact, in the press release involving the Anthem Cigna proposed merger, it was specifically mentioned that this would give this new entity increased market negotiating power with respect to drug prices. National insurers are also buying or aligning with independent pharmacy benefit manufacturers, or PBMs. And PBMs are companies that are in the business of negotiating prices with manufacturers and managing the drug benefit for insurers. So we see Anthem aligned with Express Scripts, Aetna is aligned with CVS Caremark, and United Health Group actually owns two PBMs, Optum RX and Catamaran. And this close alignment gives them an ability to share data and work together to really have a huge marketing power with respect to the manufacturers. PBMs themselves are also expanding the scope of services that they provide. We see vertical integration with CVS and Caremark, and Walgreens having its own Walgreens PBM. And then, more importantly for this discussion, we have PBMs offering new services, particularly in the area of genotyping, with Medco acquiring a genotyping company, Medco being another PBM. And genotyping is important because the new specialty drugs often work better for certain people with certain genetic makeup than for others. And if you have an ability to provide genotyping, you could provide some very sophisticated services to the likes of United Health Group or United Health Plan or to other direct purchasers, and then be able to help them use the specialty drugs in the most effective manner. Next slide. There was a recent survey of 42 plans representing 161 million people about how they were responding to the increased pharmacy costs. And most of them said that they were really interested and were focusing attention on doing things with the expensive drugs, particularly the Hep C, oncology, rheumatoid arthritis, multiple sclerosis treatments. And they were specifically looking at outcomes contracts. That is tying pricing to outcomes in the clinical environment. They felt that this was more feasible to talk about now because of increased availability of both clinical and pharmacy claims data so that they could meld them, and that there is more availability of what is called effectiveness research. And I'm going to be talking about that more. On the next slide, please. So what's happening is that PBMs and national plans are now beginning to implement this value-based pricing models that ties pricing to outcomes. Manufacturers are now in a receptive mode because of the outrage that has been expressed in multiple forums about the price increases that have been imposed on the public. We're going to look at 4 different types of value-based pricing: effectiveness pricing, performance pricing, indication-specific pricing, and one that is a cap on financial exposure, which isn't quite the same as the other, but encourages effective use of drugs. These strategies are applicable to new, very expensive drugs. It's harder to implement once a drug has already been out in the marketplace and the price has been increased. So it's most effective before the drug has been launched and just at the point of it being launched. So effectiveness pricing. What that does is it converts evidence around how good the drug is, how many people are likely to use it, what kind of funding is available for new drugs to come into the marketplace, and using all that information to set a benchmark price on what that drug should cost compared to other treatment options for that same illness. And it's a very esoteric kind of analysis. Very few organizations do this. And one of them is the Institute for Clinical and Economic Review, ICER. They've really taken this on as their cause. Drug Abacus also does this work, and you can Google them online and get information on what they're doing. The American Society of Clinical Oncology is starting to do that for oncology drugs. And of course, some national PBMs are trying to do their own assessment of what is a fair price. Next slide. So just to give you a little more understanding of how this price is set, I'm going to look a little bit more into how ICER does its pricing. So it starts out by estimating the total dollars available for new drug coverage. And they look at historical data and they project forward. And then they look at the pipeline of drugs that's seeking approval from the FDA and estimating when the FDA will be making its approval decisions. So it can then divide through the number of total drugs that are going to be coming out that are new into the total dollars that are available to get an average dollar available. Then for those drugs that they think are going to come out, they look at the clinical trials to figure out how effective they are and what the adoption rate is going to be. They then calculate at the estimated market price what the budget impact would be. And then they do what is calculate a per quality adjusted life year. In other words, the potential benefit that the individual could gain by additional life years using the new treatment compared to the old treatment. Just a moment. I apologize. They then create a value-based price benchmark that reflects this estimated improvement in the long term.
We're just going to pause for just a moment in our webinar, and we'll be right back to you in about 2 to 3 minutes. Thank you for your patience.
Well, I'm sorry. I apologize. I'm back now. Sarah?
Hi, Marge. We're glad to have you back, but take all of the time you need, and we'll reconvene our webinar when you're feeling better.
At least you can cut that out when you put it online. You know, I'm going to go get some hot water. I apologize. I'm going to do that.
Great. We'll be pausing our webinar for another minute or two, and we'll reconvene in a couple of moments. Thanks so much for folks on the line.
Okay, Sarah, I'm back. Are you able to cut out the dead space in the online, and should I start at the top of slide 22?
Absolutely.
Okay. Tell me when you're ready to start.
Go for it. Folks on the line are ready to listen.
Okay, so let me just give a little more background about how ICER does its methodology so you can understand a little bit better about how the process works. So they start by estimating the total dollars available for new drug coverage annually. They do that through historical projections. And then they look at what the pipeline is for FDA approval to get a sense of the total number of drugs that are going to be available. And then they divide through to get an average cost of dollars available for each particular drug. They review the clinical trials for these drugs that they're looking at to see how effective they are and what the adoption rate is going to be. They then calculate if that adoption rate at market prices went into effect, what kind of dollar impact that would have. Then they do what is called a cost per quality adjusted life year. They look at the value of how much of an additional life it can be valued at compared to other treatments. And then using this information, they then say, to get the best out of this drug, to make it available to the people who can benefit from it most, given the dollars that are available, it should be priced at X dollars. They have a very expansive vetting process where they then review their analysis and their assumptions and all the projections they do with a panel of experts so that it has a sense of legitimacy and reasonableness. Next slide. So one of the ones that one of the analyses that they did that just caused a huge stir in the marketplace was they created an effectiveness price for the new class of cholesterol drugs. And they found that the effectiveness price would be 45 to 65% lower than the market price that the manufacturer had indicated that they wanted to be sold at. Now, nobody has adopted effectiveness pricing as a way to set its prices that it's willing to pay. It is right now a vehicle for discussion, and it is a way of opening up and exposing drug pricing methodologies of what's happening in the marketplace compared to a more systematic scientific pricing based on estimates of how effective the prices and what dollars are available. So it's opening up discussion. There are definitely challenges to this methodology. There's no single clearinghouse for effective price analysis, so you can get different prices that come out. Pharma, which is the lobbying group for the pharmaceutical industry, challenges the methodology. They say that it is not valid and their methodology is just as good as this other methodology. So using it to negotiate prices would be difficult and would require significant negotiating leverage. This is a methodology that applies to new drugs. So it is limited to the relatively small number of new drugs that come each year and the ones that are expensive. Also, finally, there's a possibility that the value-based pricing could be higher than the market price. So let's go to then on the next slide to the second methodology, and this is one that is being implemented right now. And what it does is it sets a final price of a drug based on whether the drug performs actually in the clinical environment as expected compared to what it's expected to do in clinical trials. And the idea is that the price would be lower if the price does not perform And how these pay-for-performance arrangements are structured really is based on the nature of the drug and how effectiveness is measured. But I want to emphasize performance is based on actually what's happening in the field. So I have 3 examples. The first one is Cigna negotiated a deal with the manufacturer on these very same cholesterol drugs that we talked about under the effectiveness pricing. And they worked out a deal that if the patients taking the new drugs do not lower the cholesterol levels as expected based on the clinical trials, then the manufacturer gives them further discounts, which obviously lowers the ultimate cost of the drug. And this would apply not just to the people who are taking the drug that it didn't work for, but to everybody, all the patients taking it. But if the drug did work as expected, then the originally negotiated price would be in place. 2 more examples. The manufacturer of myeloma drug pays for the drug cost for any patient who fails to respond after 4 cycles of the drug. So a patient takes the drug for 4 cycles. If they haven't responded, the manufacturer basically reimburses the plan or the PBM for the cost of that drug. And clinical trials have indicated that the effectiveness would be known within that time frame. And then another example along the similar lines is that a manufacturer of an MS drug provides the drug free for the first 2 months because clinical trials have indicated that it is effective only in 40% of patients, and they know that very quickly. So that's how they're starting to structure these new drug pricing arrangements. There are some challenges. You've got to be a big player in the marketplace to be able to negotiate these kinds of deals. So it's the national plans and the top PBMs that are starting to do that now. And as I mentioned, the Cigna Anthem merger explicitly said that this merger would give them more negotiating power to do that kind of work. One of the biggest challenges is that both pharmacy and clinical data have to be tracked in order to evaluate whether the drug is effective. And that's easy to do on small pilot, or easier to do on small pilot bases than it is on a large scale basis. So if we're talking about this LDL drug or this cholesterol drug, that patient's LDL has to be known before and during its use. So there needs to be a way to collect and report that data. You meaning the drug manufacturer and the PBM, need to decide well in advance what the methodology is going to be for calculating whether the drug is effective. What happens if the patient has an inpatient admission and some other things happen? What if the patient stops being covered by that particular manufacturer? How's that accounted for? All that kind of thing has to be worked out in advance, and it's likely that unanticipated methodological issues can arise. We're talking about drugs that have potential long-term benefits, but effectiveness needs to be measured in a relatively short period of time with clear biomarker so that this methodology can be implemented. PBM contracts often can run 2 or 3 years, but no longer than that. And you can see that in some of the examples, we're talking about 4 or 5 months to determine whether it's effective or shorter. And you may need physician engagement, which may mean additional reimbursement to that physician for additional assessment and reporting. And as I've indicated, it does impact a relatively small number of drugs. And then the third, starting at slide 30, the third type of pricing is indication-specific pricing. And what that is to set different prices for different indications or for distinct patient subpopulations. And so the prices are varying based on the relative clinical benefit. Express Scripts has put out a statement that it wants to see differential pricing for a particular cancer drug that is more effective against lung cancer than pancreatic cancer. Same drug used for two different conditions. So they're willing to pay more for the drug when it's used for drug cancers, but less when used for pancreatic cancer. This has a potential significant administrative burden based on how PBM payment systems work. So it's difficult to pay on the basis of symptom rather than on drug. The systems aren't set up to do that. And if there's a cost sharing based on price of a drug or use, it's difficult to have different co-pays or co-insurance based on different diagnoses. It takes a lot of analytic capabilities to implement this. They may not be available, and it may be difficult to explain to patients, and particularly if there's a difference in out-of-pocket costs for the patient. And then finally, there is some interest in trying an idea of setting a cap on total financial exposure. So I, as a PBM, would come to an employer and say for a particular kind of drug, which is a new expensive drug, your exposure is limited to X dollars. And this would then incent the PBM to work with the health plan to make sure that the use of this specialty drug is done in the most effective way. And in the case of Express Scripts, the conditions are that you need to use their specialty pharmacy and follow their pharmacy management protocol. The benefit is that if the consumer spends more than the preset amount, Express Scripts absorbs that overage. Next slide, challenges. This is in the conceptual stage. You, as a purchaser, would need to figure out whether the cap that Express Scripts is suggesting is reasonable or not. And it's hard to do with a new drug with no experience, and you really need to rely on PBM assumptions, and it may be a challenge to assess whether those assumptions are realistic. So what can be done? You're a commercial plan or a purchaser. What can you be done? What can you do about these new drugs that are coming in the market and the whole development of this value-based pricing? The first is you've got to become knowledgeable about market pricing developments and new drug launches. This is a proactive strategy, not a reactive, the price is already out of the gate and rising strategy. So one thing that could be done is to support and track drug effectiveness research that's being done by ICER. They have public reports available. There's opportunities to submit public comments. This information can be used in performance discussions with PBMs. It can be used in setting member contribution levels. It can be used in educating the provider community. One of the most effective things a commercial plan can do is really actively manage that PBM contract. Meet regularly with the PBM folks to talk about current cost drivers, new drug pricing trends, new drug development, what strategies they are using, including performance-based pricing. Collaborate with the PBM on this pharmacoeconomic studies to value outcomes and financial benefits. Have them sponsor some ICER research. Include requirements that they do this effectiveness pricing analysis and to share the results with the plan. And require the implementation on their part of value-based payment models where the savings are returned to the plan or the purchaser. So it's really working actively. It's unlikely that a Vermont-based commercial plan would have enough buying power itself to work independently on this strategy. So the best strategy is, in my opinion, is to work with your PBM. For the Medicaid agency, for DEVA, DEVA is part of a purchasing coalition called the Sovereign States Drug Consortium, and that entity has in turn contracted with the Gould Health Systems to negotiate PBM pricing. And so it's important to work through these organizations to negotiate value-based pricing arrangements with their PBM. And it's also critical that the pharmacy staff within the Medicaid program work to identify new drugs that would be candidates for performance-based pricing arrangements and include them in discussions with the consortium. Note that this pharmacy staff is already working with the AG to identify drugs that have already got price increasing issues. But this is, as I said, a pre-pricing strategy. So this coupled with the strategy that's being pursued through the drug transparency pricing strategy really develops a good rounded strategy for looking at the highest priced drugs that are coming down the pipeline or are in the marketplace. There is also an opportunity for the legislature to strengthen unfair trade practice legislation to cover drug pricing at levels that are not supported by ICER or other drug effectiveness analysis. Basically say drug prices that are substantially above those benchmarks are unfair trade practices. And that would strengthen the AG's power to pressure those drug manufacturers to lower the prices. So I'm available for a question and answer session.
Thank you so much, Marge. Want to now make sure that all participants know that we can take questions. As a reminder, you can submit them by typing into the questions pane of your webinar control panel. I will facilitate our question and answer session. And so the first question we have is, Marge, you talked about some things that states are trying, and it seems still to be early days, but what kinds of savings could a state expect from implementing one of the approaches you outlined?
With the increased presence of these biotech drugs in the marketplace, there's going to be more and more opportunities to do this kind of pricing. And so I'm not going to put a percentage out there, but I think that it's a very important strategy to pursue because within 2 years, these specialty drugs are going to be represent half the marketplace in the pharmaceutical world. No opportunities. And we saw when the Hep C market or drug hit the market, and there were no breaks on those prices. They just were out of
Marge, you're fading in and out a little bit, so unfortunately we're not getting your whole answer. I wonder if you could get a little bit closer to the microphone, please.
Sure. Just real briefly, with the growing presence of the specialty drugs in the marketplace, they're going to be over half the cost in 2018. There's more and more opportunities to pursue this strategy. And we saw the Hep C drug launched with no breaks at all in the price, and what a devastating impact it had on Medicaid programs throughout the country. So that drug is a real wake-up call for Medicaid programs and commercial programs to really use this strategy to anticipate and get some things in place before those hit the marketplace, and they can have a fairly substantial impact.
Thank you. A second question we have is just in thinking about how states are looking at their prescription drug reforms and also simultaneously looking at other value-based purchasing efforts, are there natural ways that these pharmacy-specific and pharmacy-focused initiatives could fit into broader state efforts around Medicaid value-based purchasing, bundled payments or population-based payments, things like that?
Yes. As I mentioned, one of the things to be that could be used from the effectiveness research is do some education around your provider network. So there could be opportunities based on what kind of PBM contracting arrangements, what kind of arrangements the PBMs have been made around certain drugs to incentivize your providers to use these specialty drugs in a way that's aligned with the way to get the best outcome from those drugs and use them most effectively. So there could be alignment around the incentives that the drug companies have to around effectiveness, pricing, and how you are incentivizing your providers.
Thank you. And then a final question before we wrap up. We talked a lot about focusing on state efforts and state activities. What could be done at the federal level to support value-based payment for pharmaceuticals?
I want to rephrase that as a broader question on what can be done about pharmacy costs on the federal level. I think that one of the key challenges is that pricing has become a political issue. As we saw in the ACA, the federal government Medicare program was specifically prohibited from negotiating pharmacy prices. And that became, I think, a very illogical position. And that has created differential between what Medicare can do on the federal level and what states can do through the Medicaid program on the state level. At the same time, we look overseas, and the most effective strategy is when the whole country is negotiating as a unit on behalf of all purchasers, state purchasers, in these programs. You've got England and Belgium and Germany doing effectiveness pricing and then pricing the drugs nationally. And that is the most effective way to do it. Certainly the federal government could support more effectiveness pricing so that more information could get out in the environment for discussions. What can be done on a negotiating basis, frankly, we're going to have to wait until after the upcoming election to see if any of the political environment shifts.
Thank you. So thank you to Marge, and I want to thank all of you for attending today's webinar on value-based payment strategies for pharmaceuticals, and especially to Marge Huey from Baylor Health Purchasing for presenting on this important topic. Once you leave today's webinar, you will receive a survey on the presentation, and we would appreciate if you would complete that and provide your feedback. You will also receive a follow-up email within 24 to 48 hours with a link to view a recording of today's webinar. On behalf of the Vermont Healthcare Innovation Project, thank you for joining us today and have a great rest of your day. Thank you.